This session covers common GI medications for CMAs. The goal is not advanced pharmacology. The goal is for you to recognize common medication classes, connect them to common GI problems, reinforce simple teaching points, and notice when something sounds unsafe or needs follow up. To keep this organized, let's start with acid suppression medications. The most common group here is the proton pump inhibitors, or PPIs. Examples include omeprazole, pantoprazole, and esomeprazole. These are commonly used for GERD, gastritis, and ulcers. A very practical teaching point is that PPIs are often taken hashi before meals, and patients should know they may not work instantly. Some patients expect one dose to solve symptoms right away, so setting expectations matters. Also, remember that long-term use may need provider review, so MA should not casually suggest indefinite use without checking the plan. Another acid-related group is the H2 blockers, or H, such as famotidine or Hinsao. These may be used for milder reflux or breakthrough symptoms. Antacids are different because they are used for more immediate symptom relief. Next, let's move from acid medicines to constipation medications so the categories stay separate and easy to remember. Common examples include polyethylene glycol, senna, bisacidil, and docusate, along with prescription constipation medications in selected patients. One important teaching point is helping patients understand the difference between a medicine used for more regular daily control and a medicine used as needed. It is also helpful to reinforce hydration and to remind patients to follow the provider's instructions rather than making up their own schedule. For facial diarrhea and IBS-related medications, you may see loperamide and dicyclomine, and in selected patients, SAR or rifaximin or other IBS-targeted medicines. So the key safety message here is that not all diarrhea should be treated the same way. If the patient has bloody stool, fever, or severe pain that needs attention before anyone focuses on symptom medicine alone. For choice in nausea, common medications include ondansetron, and promethazine, or for pylori treatment. Like patients may be on a combination of antibiotics plus acid suppression. This is a good example of why medication review matters. Patients may not understand that they are on a multi-drug treatment plan, or they may stop part of it early if symptoms improve. Now let's talk about medications. These may include mesalamine, corticosteroids, immunomodulators, and biologics. You do not need deep medication science here, but you do need to understand the MA support role. That may include monitoring for side effects, asking about infections, helping with labs or infusion coordination, supporting prior authorization, and reinforcing adherence. For GERS, liver-related medications, examples may include lactulose, sometimes diuretics in selected liver patients. Again, the point is recognition and support, not prescribing decisions. Medication review in GI clinic needs to include more than the prescription list. Ask about over-the-counter medicines especially on NSAIDs is there, plus supplements and any symptom medicines the patient takes on their own. That matters because NSAIDs may connect to ulcers or gastritis, and self-treatment may change the clinical picture. Let's make this practical. If you are teaching a patient about a PPI, you might say, this medicine helps reduce stomach acid. It is often taken before a meal. It may take some time to work, so follow the instructions you were given. If you are reviewing diarrhea medicine, you might remind the patient that blood in the stool, fever, or severe pain should be reported rather than simply covered up with symptom treatment. The big takeaway is that MAs do not need to memorize every medication in GI practice, but they do need to recognize common medication groups, understand what they are generally used for, reinforce simple teaching points, and catch safety issues during medication review.